prediction of preterm labour, interventions to prevent preterm labour, tocolysis in preterm labour, and conclude. Hopefully I can finish it by 20 minutes if I can, because we are a bit tight in time. So let me just take you through about a bit of introduction. Preterm labour remains the leading cause of perinatal morbidity and mortality in many parts of the world. And the majority of this preterm birth occurs in women without any identifiable risk factors. The funny thing about preterm labour is we are so preoccupied with managing patients who have got previous history of preterm labour. But again, these women are the ones who are doing alright. End of the day, you are just hoping that she doesn't go into preterm labour. She never goes to preterm labour, she ends up delivering at term. But the one which goes up into preterm labour are the one we are not focusing on them. They are low risk mothers, everything is fine. Suddenly they end up having preterm labour. So it's very difficult to predict which mother is going to end up having a preterm labour. So we need a very good tool to predict preterm labour so that it can help us in our management. So do we have one? That's a big question. Okay, when you talk about preterm labour, a lot of previously about 5-6 years ago, there's a lot of courses which have been put up. But recently, over the past 5 years or so, Roberto Romero, who has been a frontliner in the research of preterm labour, has come up with this concept of one syndrome, many causes. Okay, he feels that the preterm labour is caused by various causes. What they call interplay of various causes such as infection, vascular disorder, deciduous senescence, uterine overdistension, decline in progesterone action, cervical disease, breakdown in maternal fetal tolerance, stress, and in fact, some of the causes we don't know. It just happens. So all these causes come together and it has got an interplay. That is what he says after so many years of studies which is done. So the definition of preterm labour, when you talk about definition, it's delivery before 37 weeks. And of course, what is important for the neonatologists is they categorize this preterm labour. You've got extreme prematurity, which is less than 28 weeks, which is about 5%, and near term, or they call it late prematurity, which is about 34 to 36 plus 6, which is about 60%. This is the one which we tend to see quite commonly. And survival rates increase dramatically with improvement in neonatal care. So, premature delivery of birth has been a talk worldwide. Okay, everywhere people are talking about premature delivery. But the funny thing about premature delivery is, when you talk about, in fact, when you talk about premature delivery, there's more than 1 in 10 babies born prematurely. And the most interesting thing is, the rate is the same worldwide. It's about the same worldwide. Even you take in US or even you take in Somalia or Thailand, it happens to be about the same. There's not much of a difference. So what it tells you, it only tells you that the causative factor is the main problem. It is not because, it's not what's the intervention you're doing, it's not what's the treatment you're doing, the causative factor. So it looks like we are not able to stop this premature labour from happening. So when you talk about the worldwide problem, the magnitude of problem, you will realize that you see that some countries have got very high rates, especially the African countries. The developed states has got slightly lower, so not so much of significant difference, I would say. And when you talk about where it happens according to continent, you realize that it happens a lot in sub-Saharan Africa and also Southern Asia. Okay, where in Southern Asia you have nearly about 13.3% of babies going into having mothers having preterm birth. So the other interesting thing is most of the preterm births which happens is about 32 to 37 weeks. And you will also realize that in more than 75% of deaths of preterm birth can be prevented even without intensive care. So what is important is you intervene, you predict and you intervene early. So that is something which we have to always have in our mind. So there has been a lot of comparison which has been done with high income country, middle income country, low income country. So we fall into the middle income country. But when you look at the statistics, you realize that there's not much of a difference. So as far as Malaysia is concerned, we are stuck somewhere around about 14%. Compared to US is somewhere around 12%, I would say. So not so much of a difference. But we can make things better. We can work towards making things better with certain strategies in place lah. So when you look at preterm birth, you will see that whenever the gestation is much lesser, the survival is of course much lesser lah. That goes without saying. And you realize that once the baby reaches about 32 weeks, the survival rate is much better. Again, this depends on individual setting. Where are you working? Where are you placed? For instance, in Hospital Sultanah Bahiyah, you are quite comfortable if the babies are above 34 weeks. I'm sure most of the hospitals are as such. I don't know whether different hospitals from different states are 28 weeks. The neonatologist is very happy. Most of the time we have to haggle with the neonatologist, pediatrician. Sometimes they don't talk to us because we deliver babies too early for them. They don't even communicate with us. But if you give them babies after 34 weeks, they're quite happy. So they blame us for everything. I hope there's no pediatrician or pediatrician husband or wife here. So don't tell your spouse. Later they won't be so happy. But this is the secret. Most of the time we always have got this thing against them, and they got something against us. So whatever said and done, we try as much to work together because to achieve the best results. Also, you also will realize that the babies born much earlier have got much higher complications in terms of respiratory distress, sepsis, intraventricular hemorrhage, necrotizing enterocolitis, and so on. So the earlier you deliver, the more problems is at hand. And also, I hope Dr. Muriza is not here. I'm not going to offend her. Triplets has got higher incidence of preterm delivery. So the more eggs are inside, the more embryos are inside, the higher the risk of preterm babies and higher the headache we have with the neonatologist. So, okay, why is it an issue? It's an issue because of the cost. Alright, the cost is mainly an issue. So this is our rates. We are somewhere around 12. I think now it's improved. 2015 is about 12 point something. 90% of the preterm babies stay more than 8 days. And average cost is about 15,000. We're talking about a government setting. So a baby which is born in a private setting, nurse and pre in NICU, per day it can go up to about 40,000. Okay, can you imagine? So that is why we always have issues, because the preterm babies, preterm mothers who are having preterm contractions in a private setting, they would want us to transfer to a government hospital, and they are limited. They've got a limited space. Sometimes we don't have a choice. The babies are born there, and they are being ventilated there, and the cost is very high. So the problem with this is, the whole problem with preterm birth is that those women with history of previous spontaneous preterm birth accounts for only about 10% of all births. Okay, which is less than 34 weeks. Meaning those with previous history of early delivery, only 10% of them actually do have delivery. Most of them wouldn't have any risk factors. Okay, so sometimes it's very difficult for us to predict which woman will be ending up having a preterm birth. So we're so focused with this group of women that we forget about other women. Okay, whereas the other women who finally end up with preterm birth doesn't have any previous history, they are the ones whom we ignore. So we are so preoccupied with that because we always look into risk factors. This is the one we're always looking at. History of preterm, spontaneous preterm birth, and previous preterm premature rupture of, in fact, preterm premature rupture of membrane, current pregnancy, antepartum hemorrhage, uterine over-distension, and the whole lot. These are the ones we consider as risk factors. So again, this doesn't give us a very good, what shall I say, risk stratification. Okay, just to put up this very interesting picture, these are celebrities and icons. Can you tell me what is something common in them? These are all preterm babies. Okay, Albert Einstein was a preterm baby. The mother was very worried because he saw that his head was so big and so large and oddly shaped. So when he sent him to school, the mother thought that he will have intellectual development, problem intellectual development, but he became one of the top students in the class. From then onwards, history. Okay, so this is Sidney Poitier, this is I think Alfred Hitchcock, and we have got William Harvey, Stevie Wonder, all the celebrities, and these people are very intelligent people, so don't underestimate preterm babies. Okay, so how do you approach this whole what you call area of preterm labour? So we can actually divide it into 3 areas, which is prevention of preterm labour, prediction in those women at high risk, and interventions to prevent those at high risk. We cannot be doing universal screening. So we don't have a choice now. We still may still have to focus on high risk patients who have got background history. So this is how we can go about. We cannot be screening all women, do a TDS for all women to check and see whether they are at risk of having preterm labour. So when you talk about prevention and prediction, when you talk about prevention, we start off with the primary prevention. What is primary prevention? Primary prevention, basically, one of the most important thing is contraception, because contraception will optimize the birth interval. Because the space is much lesser, the mother gets pregnant regularly every year, the risk of you having a preterm baby is high. So this is utilization of single embryo transfer, where IVF, Dr. Muriza is not here so I can talk. So hopefully everybody puts in a single embryo, don't put more than a single embryo. So if you put a single embryo, there's twins, they say it splits after you put it in. So we understand, you understand, you say it splits or it's a triplet, you understand. But again, we don't have a proper legislation as yet in Malaysia. I hope it's already coming up quite soon, I heard. But utilization of single embryo transfer is very important. Using of progesterone, smoking cessation, these are some of the primary prevention. Secondary prevention, if we think that the patient has got previous risk factors, we can give them vaginal progesterone, cervical surplus, tocolysis sometimes. And these are second preventive methods. Okay, let us look at prediction. How can you predict women who are at high risk of preterm labour? So there are two modalities which you can consider. One is transvaginal scan, another one is fetal fibronectin. So when you talk about transvaginal ultrasound, transvaginal ultrasound has been used to measure the cervical length and funneling as a screening test for preterm labour. So this is known as funneling. You can see the funneling, maksudnya the internal os is opened up. So there's already a funneling here. Okay, this is known as funneling. So the other thing is you look at the cervical length measurement. These are the two parameters which are very thought to be very, sensitive in measuring or predicting those who might go into a preterm birth. And the cervical length at 24 weeks is shown to be normally distributed somewhere at a mean length of 35. So most of the guidelines have taken 30 millimeters. So remember 30 millimeters, it's a round figure. So at 24 weeks, if the patient has got 30 millimeters and more, you don't have to worry. The chances that she is going to go into preterm labour is extremely remote. So this is something which has been validated even by Cochrane database. So this is one of the important message which you can take back. And in a normal pregnancy delivered at term, the cervical length stays relatively constant until the third trimester. So as I mentioned earlier on, funneling basically means it's opening of the internal os. So it is actually it has been shown to be associated with independent risk factor for preterm labour. So there are stages of this so-called funneling, but again there is a degree of funneling. The funneling becomes more extensive, meaning that the risk of them going into preterm labour is very high. So these are the stages of funneling, we call it. So it's in a T shape. This is by ultrasound, by transvaginal ultrasound. It appears to be a T shape, then it changes to Y shape, then V and U. Trust your vaginal ultrasound. Easy to remember. Okay. So if you are in a clinic kesihatan, if you are in the hospital daerah, the best method for you to use is transvaginal ultrasound. Unfortunately, you cannot do much with the abdominal ultrasound. So that is why we always advocate any health setting, clinic setting, to still have a transvaginal ultrasound, because the patient who has got previous risk factor, we need to do a TDS to measure the cervix. Okay. So as I mentioned to you earlier on, the measurement of 30 millimeters at 24 weeks has got very high negative predictive value, which is 90%. So you do a measurement at about 24 weeks, if it's more than 30%, you can tell the mother that approximately 90% you wouldn't go into a preterm labour, right? So this gives us, this will tell us that we don't need to do unnecessary intervention for those patients whom we think has got the length is more than 30 millimeters. The next will be fetal fibronectin. So when we talk about fetal fibronectin, what is fetal fibronectin? It is actually an extracellular matrix glycoprotein localized at the maternal fetal interface, the amniotic membrane. So what happens is that when you have disruption of the membrane, there will be positive for fetal fibronectin. Okay. And it's a very straightforward, simple test. It's a non-quantitative test, gives you a positive or a negative result. So you just take a swab to see if it's positive or negative, right? So if it's positive, then of course there's a risk involved. So there is also commercially available, there is known as actin parters and so on. So it has been shown to have a good correlation between preterm birth and quantitative assessment of fetal fibronectin. Sensitivity is about 76%, specificity 81%, and its negative predictive value is 99% for delivery within 7 days. So what it means that if you think that it is negative, so you can tell the mother that most probably you wouldn't go into labor, very high percentage you wouldn't go into labor, alright? So it's about 99% over the next 1 week or so. But if it's positive, then it's the other way around. So people have looked at using this as a predictive tool, either individually or in combination. But they realize that if you use both tests in conjunction, then the pickup rate is very good, alright? Meaning that, let's say, you have got a transvaginal ultrasound, the cervix is less than 1.5 or 15 millimeters, and fetal fibronectin is positive. So you combine both tests. So you can tell the mother that if you use both the tests, for her to deliver in 48 hours, the risk is about 50%, about 40% or so. You can also tell her that the risk of her not delivering is about 75%. So delivering is about 75%. So you can use this in combination. So if it's positive, you can say that the risk of them having a delivery in about 48 hours is about nearly 50%, and about a week is about 75%. So you don't discharge the mother. You keep the mother in the ward, you monitor them, or you do some intervention. Okay? So this is how it will help us, these two tests. So always we can do that in a combination. But the problem with us is that we don't have the fetal fibronectin tool because it's expensive. So we depend on our transvaginal scan. So what are the interventions now? What are the things we can do to prevent preterm labor? So there are several things you can look at. There are several modalities you can look at. Cervical sutures, use of antibiotics, progesterone, cervical pessary. Even there are others, but I'm not going to go into others. Let us look at cervical suture. Okay, so this has been introduced as part of treatment for cervical incompetence. Cervical incompetence meaning that you have got inherent weakness of the cervix. The cervix actually dilates. Okay, what happens suddenly? The mother is not having any contraction. Suddenly the os is nearly fully open and the baby just comes out of the sac. That's a very typical history, like what Dr. Muriza presented earlier on. But the problem with this is very difficult to diagnose. So the first pregnancy, she may have a typical presentation. The second pregnancy, she might, go up to near term deliver. Third pregnancy, she might have an early delivery. So sometimes it's very difficult for us to come with a typical cervical incompetence. So then we are stuck. We have got a problem. So this procedure is, let's say you diagnose the patient to have a genuine cervical incompetence. The best time for us to do a cerclage is somewhere around about 14 weeks or so. So when you can actually also do as an elective procedure, or you can do it as an emergency procedure, right? So this cervical cerclage or cervical suture has been described very early in 1954 by Shirorka, McDonald's in 57, abdominal cerclage. Abdominal cerclage we rarely use. We use it when there's extreme shortening or scarred cervix. We cannot see the cervix, very short. So we cannot approach vaginally, you can do abdominally. Or if when TVS, transvaginal cerclage previously failed, then you can do an abdominal approach. So basically, we have got the McDonald suture. It's a purse string suture where you take 3 knots around and you tie in the anterior. Okay, some actually do tie in the posterior. It depends. Where Shirorka is actually you go through the cervical tissue. They say this is a more difficult procedure, but it's less infective. Whereas here this is prone for more infection. So there's a difference, but this is much easier to perform, and we take it out at about 36 weeks. The problem is it can cause rupture of membrane, bleeding, pregnancy loss, bladder injury, risk, anesthetic risk. So when do you do it, and which group of patient do you do it? Okay, we can do it in a patient with previous preterm birth who's got typically history of cervical incompetence, or those with cervical length less than 25 millimeter before 24 weeks. You will see that when they're less than 24 weeks, we can actually perform. Maybe this can be done as an emergency cerclage. But those typically presents with history of cervical incompetence. We can do it at about after 14 weeks. Emergency cerclage is another thing which you can do when there's already open. It's already open. You can do it and below the external os prior to 26 weeks. And the success rate is about approximately 50%. So meaning that you see that there's already cervix is open. You can see that actually the membrane is bulging, but we can gently push it in. But the problem is you cannot do it if the dilatation is more than 3 cm. It has to be less than 3 cm. The membranes are below the external os, and sometimes the sign of infection takes place, you cannot do. Okay, or there's bleeding. So there's also certain limitations. We cannot, all patients you cannot do emergency cerclage. Only limited number of patients. Okay, let's look at antibiotics. Can antibiotics prevent preterm labor? What do you think? The answer is no. Okay, antibiotics cannot prevent preterm labor, but I'll tell you why afterwards. There are several organisms which have been linked to preterm labor, such as bacterial vaginosis, all these organisms. And antenatal screening treatment of symptomatic vaginal infection has been showing conflicting results. Meaning you treat mothers who have got vaginal infection, you realize that sometimes they still go into preterm labor. So there is conflicting results. And this study, which is a significant study, known as Oracle 2 study, 2008. So what they did was they started antibiotics for patients coming in with preterm labor, and they realized that it did not prolong the pregnancy. There's no difference in composite primary outcome. And the recommendation was the routine antibiotics. The summary final statement was routine antibiotics is not recommended for preterm labor with intact membrane. The most important thing is intact membrane. Okay, meaning that mothers who has got preterm labor, there is no role of simply starting off antibiotics. But now there has been evidences in the recent guideline from Royal College has shown that it is you can do it to prevent GBS, Group B streptococcus infection. But having said all that, one of the things which we can prevent is it has been shown that early preterm birth is likely to be an infective cause, especially in the treatment of bacterial vaginosis. Because when they did a study for in early labor, less than 20 weeks, they realized that when they treat this group of mothers for bacterial vaginosis, it did prolong the pregnancy. Okay, so meaning that in those mothers who have got evidence of bacterial vaginosis early, if you realize they got bacterial vaginosis early, you give antibiotics. It has been shown to reduce the risk of PPROF and low birth weight. This has been shown by in Cochrane database, but not the one coming later with evidence of preterm birth. Okay, move on to progesterone. I think progesterone, Dr. Moriza has spoken to you about everything, so I'll just perhaps do not to bore you. Maybe I'll skip some slides. Progesterone is an anti-inflammatory agent, so it acts by inhibiting myometrial contractions, vital ripening, down-regulates gap junction, and also inhibits chemokine production. So what happens is that the role of progesterone is to maintain the uterine quiescence, meaning that it makes sure that it stays stable. It doesn't go into intermittent, irregular contractions, and that is what progesterone will do. Okay. So recent evidence have shown that progesterone reduces the risk of preterm labor in a singleton pregnancy and a previous history of preterm delivery. So this is very important. The previous preterm delivery and a singleton, it doesn't have any effect on multiple pregnancy twins. It has shown a very positive, positive results and findings, and then with the number needed to treat and to prevent is about 1 preterm labor to 16, meaning you need to treat about 16 of them to prevent 1 preterm labor. So this is the recent evidence. So what are the options we have? We have got vaginal progesterone, or we have got 17-alpha hydroxyprogesterone caproate, which is 17-OHPC, given intramuscularly. So basically, it has shown good results, and but then it doesn't show any improvement in neonatal outcomes. So there are some recommendations. In fact, this is a Canadian guideline which actually shows that if you have a previous spontaneous preterm labor, cervix is short, you can actually give progesterone therapy. You can start after 20 weeks, right? You can either give the injection, which is 17 OHPC, or you can give vaginal progesterone 100 mg daily till 36 weeks. Or to prevent those with short cervix, you can give about vaginal progesterone 200 mg daily vaginally till 36 weeks. Okay, cervical pessary, this is very interesting. This cervical pessary is something which you can imagine. It's like a pessary and you just hook it into a cervix. Okay, it has been tried for incompetence since the 1950s, and a lot of studies has been done, and most of it is you use the Arabin pessary. It's like a ring-like silicone pessary. But again, there has been a lot of different studies, also conflicting studies. Some actually showing a lot of benefits, some did not show so much of benefit, and so on. So there is one study known as PERCEPT study, which has shown benefit in a group of patients. One or two studies did not show much benefit. So this is something from New England Journal of Medicine, which did not actually show much of did not lower the results of preterm delivery. Again, this is just one paper. There's so many other papers which actually has come out with positive results. If you want to know more information, you can visit Surgimetrics. Mr. Justin is there. He will tell you more about the Arabin pessary. He's one of our partners. Okay, in a nutshell, when you have a baby which is about to be delivered prematurely, preterm labor, the role of progesterone is relatively good evidence in patients with previous preterm labor and short cervix. Cervical surcharge has been shown to also, to some extent, reduce preterm birth, as well as, this about the two main sort of modalities which has been shown, which has actually shown some evidence to show that it can reduce. The other thing I'm going to talk to you about after this is actually tocolysis. And antibiotics actually did not show much benefit in such a patient. So when we do a comparison, this paper is to look at the comparison between vaginal progesterone, surcharge and pessary, which, just to summarize, and what this paper actually showed was there is no, what they call, all the modalities have got similar effectiveness, okay, as management strategies with single-term pregnancy, previous spontaneous preterm birth and short cervix, meaning none is better than the other. Okay, it's about the same modality. Tocolysis, basically, just to tell you that there's no evidence to show that it reduces preterm birth. The only reason we start tocolysis is to allow time for administration of corticosteroids in utero transfer and it works for about, if you can prolong it for about 48 hours, and it can actually give a benefit for maturity of fetal non-maturity. So there are so many different drugs with different mechanism of action which can take place. I'm not going to go into details. We have calcium channel blockers, nifedipine, beta-symptotomimetics, autociban, autosomin antagonist, oxytocin antagonist, and cyclooxygenase inhibitors. And for us, what we use in majority of the MOH hospital is we use nifedipine, a calcium channel blocker. It's relatively a good drug. It's cheap, easy to use. However, there's no standard protocol as for now. So, I've come to the end of my presentation. So what can we do in a primary care level, primary care setting? One of the things we can do is identify the patient at risk. If they've got previous history of preterm birth, previous history suggestive of incompetent cervix, previous history of, let's say, they've got any cervical procedures done, you can identify them, refer to us early. So we can actually do perhaps screen them, monitor them, and also do a transvaginal ultrasound for cervical lens screening. So the key point is, currently there is absence of good predictive tool for standard treatment of preterm labor. Despite advancement in neonatal care, preterm delivery appears to be one of the largest causes of neonatal morbidity and mortality. Prolongation of gestation in these patients are definitely beneficial. And counseling of parents is one of the important factors, because most of the parents are extremely anxious. They don't know what's going to happen after the baby is born. And please, if you identify a case as such, transfer to a tertiary hospital where they got an ICU backup. That is also a very important component of management. So whatever we do, we don't lose hope, because I never underestimate the determination of a premature baby. As you could see just now, Albert Einstein, don't underestimate anyone. Okay, thank you very much.